Neck incisions. Types of neck incisions and its advantages and disadvantages. 1. Cryal incision. This incision begins from the tip of mastoid process in a curvilinear fashion up to the tip of the hyoid, extending superiorly to the submental area. A vertical limb is dropped at 90 degrees from the posterior aspect of this incision behind the carotid artery and extending inferiorly to the middle portion of the clavicle in a lazy S fashion. A straight vertical incision is likely to lead more scarring and contracture, thus a lazy S incision is used. Advantages. 1. Provides maximum exposure of the operative field. The bigger is the exposure of operative field, the better is the chance for cure. 2. Can be preferred for a radical neck dissection, modified neck dissection. 3. Superiorly can be extended from the submental area to make a lip split incision to include primary tumor. 4. Good exposure to the oral cavity with slight modification. Disadvantage. 1. Trifurcation point is prone for delayed wound healing. 2. Vertical limb of this incision overlays carotid artery, and it can lead to carotid artery blowout. 3. Cosmetically vertical limb gives more contraction and scarring. 2. Schobinger incision has two components: a horizontal limb which curves from tip of the mastoid process to the midline of submental region, and a vertical limb of the incision starts 1 finger breadth behind the angle of mandible and right angles with the horizontal portion of the incision. The incision carried down to the edge of trapezius muscle reaches to the midline of clavicle. Advantages. 1. Adequate covering and protection of the common carotid artery or of parts of it can be achieved. 2. Choice of incision for modified radical neck dissection (MRND) and radical neck dissection (RND), where the nodal disease is extensive. 3. Good exposure to the neck structures, hence good clearance. Disadvantages. 1. With respect to wound healing, it is a well-recognized principle that vertical longitudinal skin incisions in the neck tend to heal with excessive fibrosis and contracture, and the resulting scars frequently stand out prominently as unsightly cicatricial cords. 2. Higher incidence of marginal necrosis and contracture of the flap with scarring was noted. The Schobinger incision is also designed to protect the carotid artery by means of a large anteriorly based skin flap. However, the blood supply to the posterosuperior part of the flap is not good and, occasionally this area becomes devitalized. 3. McPhee incision. In this, 2 horizontal skin incisions are made, one in the submandibular region and one in the supraclavicular region of the neck. The upper horizontal incision is made on the upper cervical area from the tip of mastoid process and continuing below the angle of mandible up to the submental. The lower horizontal incision is above the clavicle and parallel to it. Between these 2 incisions a bipedicled flap is raised. Advantages. 1. Appealing cosmetic results. Well known that slightly oblique or transverse incisions usually heal with minimal scarring. Transverse incisions are adaptable to any of the usual methods of neck dissection. There is no crossing or converging of incisions and no angles, with questionable blood supply. 2. Time taken to close the flap is less, hence less surgical time. 3. Wound healing of the flap is better as the closure is simple without any converging incisions. Disadvantages. 1. Neck dissection through transverse incisions is more difficult and requires more time as the access is limited, which may lead to compromise in disease clearance. 2. Difficult to perform in short and obese neck patients. 3. Dissection under central bipedicled flap is tedious, so extensive retraction is required for proper exposure. Also, extensive stretching of the flap can compromise its vascularity at the edges of the flap. It can interfere with the reconstruction process of the neck with a pedicled flap. 4. Single transverse cervical incision. It can be considered as a modification of McPhee. Single transverse incisions have been described by Coker previously as a classical Coker's incision for thyroid malignancies. This incision can be placed in the upper cervical portion of the neck, starting from submental region within the Langer's first skin crease, and extended up to the tip of mastoid process. The length of incision can vary depending on the access. Advantages. 1. Good cosmesis and aesthetics following a neck dissection. 2. Suggested for N0 neck or endoscopic neck dissection, where aesthetics is significant. This suffices a supraomohyoid neck dissection. Disadvantages. 1. Access is limited, hence limited exposure. 2. Extensive dissection for huge nodal disease cannot be done. 3. Choice of neck dissections is limited, as MRND and RND is difficult and time consuming. 5. Hockey stick and reverse hockey stick incisions. Leahy in 1941 described hockey stick incision. The incision has two components, a longitudinal and transverse incision, but in continuation is one single incision. A low transverse incision above suprasternal notch curving superiorly is a vertical incision to reach the tip of mastoid process. She appeared to be the suitable incision for radical neck dissection due to adequate exposure of the operation field while rendering excellent cosmetic results. The difference in She and RHSI is based on difference in skin flaps. She allows elevation of a superiorly based single cervical flap, and reversed She allows for an inferiorly based flap. 6. Advantages. 1. Reversed She was applied in combination with block resection of parts of the oral cavity because it provides much better exposure of the operation field. 2. An acceptable cosmetic result. 3. She provides good exposure to parotid area, in case the parotid tissue is involved by tumor. 4. Suitable for access to all 5 levels of lymph nodes, and lateral component of the neck. 5. Both She and RHSI are gently curved single linear incisions without 3-point suture junction lines, hence good wound healing. 6. Ideal for neck dissections like MRND, RND and post-irradiated neck, as it does not form a 3-point junction and prevents wound dehiscence and carotid artery blowout. Disadvantages. 1. The vertical incision crosses the Langer's tension line. 2. Evident scarring in the neck. 3. It provides optimum exposure of oral cavity. 6. Modified J incision for exposure of levels 1 to 4. The vertical limb takes origin just anterior to the tip of mastoid and follows the anterior border of trapezius muscle and extends inferiorly and curves obtusely across posterior triangle 3 cms above the clavicle to anterior border of sternocleidomastoid muscle. Advantages. 1. The horizontal arm of J incision is flexible in terms of length and location. 2. Good exposure from level 1 to 4. Disadvantage. It cannot be used in mandibular swing or lip split to involve primary tumor. 7. Gluck incision, which is basically an apron flap incision, with a vertical posterolateral arm to approach the supraclavicular area. For a bilateral, functional neck dissection, the incision extends between both mastoid tips, crossing the midline at the level of the cricoid arch. This incision allows good exposure when the neck dissection is to be combined with total or partial laryngectomy. Sometimes the vertical arm can be avoided by prolonging the apron flap in a posterior direction, thus producing a better cosmetic result. 8. The double Y incision of Hayes-Martin is also popular for functional and selective neck dissection. A chin extension may be used when the removal of the primary tumor requires an intraoral approach. A well-known disadvantage of this incision is the compromised blood supply to the skin flap, especially in the two crossings of the incision. Thus, the vertical arm of the incision should be placed posterior to the carotid artery. The cosmetic result is improved by giving the vertical arm a slightly S-shaped curve. The modification of double Y is single Y incision, which avoids one of the crossings of the double Y incision but makes the dissection of the supraclavicular fossa difficult. Conclusion. Neck dissections are always well discussed, but neck incisions are rarely prioritized. Choice of neck incisions is deemed necessary for good wound healing, disease clearance, thus affecting overall prognosis too. Hence a thorough knowledge of neck incisions can be used to its advantage and increase its feasibility of usage. The incisions commonly used for radical neck dissection in previously irradiated patients may also be used for functional neck dissection. Incisions such as McPhee, hockey stick and reverse hockey stick incisions are ideal for radical neck dissections and irradiated neck explorations, as they don't have trifurcate areas. Whereas for modified and radical neck dissections, modified Schobinger, J-shaped, double Y incisions, etc. can be used. For superior cosmesis, where the burden of nodal clearance is less, a single transverse incision should suffice, as it follows Langer's tension lines, hence less visible scarring in the neck, giving aesthetic appeal. Hence the choice of neck incisions should be based on sound oncological principles, which can also contribute towards good quality of life.